Good evening, sir.
Good evening.
Sir, shall we start?
Yes, ma'am. Is it audible?
Yes, sir. Yes, sir. It's clear.
Learning is beginning of wealth. Learning is the beginning of health. Learning is the beginning of spirituality. Having a heart to start learn where the miracle process all begin.
Good evening, everyone. With great joy and immense pleasure, I extend a warm welcome to all the dignitaries, guests, and delegates present here for the Dr. Sudhir Raj Memorial free webinar series organized by DIKSHA E-Learning in association with Ayurveda College Coimbatore under the banner of Azadi Ka Amrit Mahotsav. In today's session, we'll be discussing about Etiopathogenesis of Kamala, interpretation of LFT in Hepatobiliary diseases by Dr. Mahesh Hirulal, Associate Professor, Department of Roga Nidana, SDM College of Ayurveda and Hospital, Hassan, Karnataka.
Before starting the session, I would like to go through a few basic instructions to be followed throughout the session. For uninterrupted class session, use laptop with high internet connection. Please make sure your microphone is on mute to have disturbance-free session. In case of any disruption, please check your internet connection firstly, and if the problem is within our network connection, kindly raise the issue in our chat box. Filling your full name to be displayed is appreciated. Any questions can be posted in the chat box. Questions raised will be cleared at the end of the session. Next, I would like to invite Dr. Jeeva, Associate Professor, Department of Shalikitandra, Ayurveda College, Coimbatore, to deliver the welcome address.
Thank you, Sahana. Good evening, one and all. On behalf of Ayurveda College, Coimbatore and DIKSHA E-Learning, it gives me immense pleasure to extend a very warm welcome to our guest speaker. As you all know, we have Dr. Concept of Etiopathogenesis of Kamala and interpretation of LFT in Hepatobiliary disorders. I extend a warm word of welcome to our guest speaker for accepting our invitation and for being with us here today. Hope this discussion will be one among the best to look into our concept in a new perspective. Let me proudly welcome all the delegates who have joined with us today. Welcome you all once again. Thank you.
Thank you, ma'am.
It's a great pleasure for me to introduce our guest speaker, Dr. Mahesh Hirulal, Associate Professor, Department of Roga Nidana, SDM College of Ayurveda and Hospital, Hassan, Karnataka. Sir has experience of 6.5 years. Sir has attended many seminars and has delivered many guest lectures. Sir has delivered 4 episodes of interview in Ayush TV regarding Ayurvedic management of hepatitis. Sir has presented papers in various national and international seminars. We are extremely privileged to have you here in this platform. Now, without any further ado, we will turn the time over to respected Dr. Mahesh Hirulal, sir.
Thank you, ma'am. I hope the slides are visible and I am audible. Thank you for welcoming. Thank you for welcoming to this discussion. First, I wish to thank DIKSHA E-Learning Academy and Ayurveda College, Coimbatore for this interview with all of you. I'm Dr. Mahesh Hirulal. So today we'll be going to discuss about etiopathogenesis of Kamala and interpretation of LFT in different hepatobiliary disorders. First, I wish to pray Lord and the happiness for all of us. This discussion will be with the two parts. The first part we will be discussing about the Kamala, then its Nidana, Samprapti and Lakshana on Koshta Shakashita and Shakashita Kamala. We're going to discuss about the laboratory investigation in liver disorders and use of the LFT and the other laboratory investigation for the diagnosis of different types of jaundice. And very briefly, we will also discuss about viral serum markers. Kamala is one of the very important Pitta Pradhana Vyadhi and Rakta Dushti Vyadhi, where the Raktavas Roto Dushti is the major involvement in Kamala, and it also major. So without the Pitta involvement, there will not be the Kamala. The derivation or the word meaning of Kamala, as we know that Kama plus the, so loss of desire of the Kama. So loss of desire. So what is the desire? So desire of the ahara, or the desire of the food is lost, and that is makes this condition to be named as the Kamala, which is the Vyadhi Namakarana Siddhanta, which is used for this naming of this condition. If you see the different contexts, so we have the Kamala, Kumbha Kamala, Halimaka, Agaraka, Alasakya, and the Panaki. So these are explained in the different contexts with the Kamala, and they are sometimes are the different stages of the Kamala. Some are the Upadrava of the Kamalas, and some are in the Kamala only at the different levels they will be appearing. So before going to the Nidana and Samprapti, first we will understand the Kamala with its types. So Koshta Shakashita Kamala and the Shakashita Kamala. Koshta Shakashita Kamala is also called as Bahupitta Kamala, and the Shakashita Kamala is called as the Alpapitta Kamala. Then Koshta Shakashita, as we know that it is after the Pandu. For that only it is called as Paratantra Kamala, and the Shakashita is the Swatantra, which has the independent origin in nature. Then the Koshta Shakashita is a Nidana Arthakara Roga and the Upadrava of the Pandu. The sequel of the Pandu, we can say that the Koshta Shakashita Kamala, and the Shakashita, where the Pitta are involved and it is obstructing the Pata, and it is also called as the Ruddha Pata Kamala. So with this brief introduction, if you see the explanation of the Kamala in Charaka Samhita in Panduroga Adhyaya, first the Acharyas has explained about the Pandu Nidana, Samprapti, Lakshana, Veda, Asadhyata, Sadhyasadhyata of the Pandu. Next, after that, suddenly the Acharya will shift to the Koshta Shakashita Kamala and the explanation about the Kumbha Kamala. Then of the Pandu Chikitsa with the Kamala Chikitsa, like the Navayasa Churna, Punaramandura, etc. Then at the end, the Acharyas will explain about Shakashita Kamala and the Halimaka. So this sequence from the Pandu, Koshta Shakashita Kamala and the Kumbha Kamala is explained, and its Chikitsa is explained, and at the end Shakashita Kamala is and the Halimaka are explained, because they are considered to be the Swatantra Vyadhis and they are independent of the Pandu, and there is a special approach is needed for the Shakashita Kamala. Coming to the Koshta Shakashita Kamala, Pandu Rogi Tartam Pittalani Nishavate, Tastam Pittam Asruk Mamsa Dagdwa Roga Kalpate. So the prerequisite for the Kamala is the person is Pandurogi, and he is again continuation with the Pittaja Ahara Vihara or the Nidanas. And what will happen? It will make the Dagdwa of the Asruk and the Mamsa. So very, very important. Dagdwa is routinely will tell that the burning or the destruction of the Asruk and the Mamsa, which will lead for this condition. And it is, there is an involvement of both Koshta and Shaka. How the Koshta and Shaka is involved, we'll see in the successive slides. For that only, this condition is called as Koshta Shaka Ashita Kamala. So coming to the Samprapti, and in each stages of the Samprapti, what are the involved factors in the conditions, we'll see First, the prerequisite is the person is Pandurogi, and it is already, we know that the Panduroga is Pitta Pradhana, Rasa Pradushirada. So Pitta is already there, and the Rasa is already vitiated. The same person or in the same condition, if the person takes the Pittakara Ahara Vihara or the Nidhana, then there is an still more Dushti of the Pitta. In particularly, it is the Ranjaka Pitta. And there is, in the next stages, there will be the Asruk Mamsa. Why the Asruk is involved? Because you know that the Pitta and Rakta is Ashaya Sambandha is there, and already Rasa is involved in the successive stages or in the next stages of the Pandu. From the Rasa, again Rakta will also be involved, where there is a Sthana Samshaya of the Pitta in the Rakta, and leading for Koshta Shakashita Kamala. And why the Koshta? Because Ranjaka Pitta. Why the Ranjaka Pitta? Ranjaka Pitta is the Sthana is the Yakrut or the Koshta, and why the Shaka? As the Shaka, we know that the Koshta and Shaka in the Prapti, that only will call this condition as Koshta Shakashita Kamala. Most of the time we will tell that Koshta Kamala and Shakashita Kamala. No, it is Koshta Shakashita Kamala and another one is Shakashita Kamala. Coming to the Lakshanas of the Kamala. Haridra Neto Sabrusham, Haridra Twak Naka Anana, Raktapitram Chakrut Muto, Bekavarna, then Daha Padari Karshitaha, Kamala, Bahupittesha Koshta Shaka Shayamta. So this Koshta Shaka Shita Kamala is Bahupitta Kamala. And a very important and a very interesting simile is given, that is the Bekavarna. So most of the time you know that what is this Bekavarna? We'll see in the successfully. So Bekavarna, all of you know that the Beka is the frog, and is this Varna. If you see in the Indian context, if you see the frog, it will be the black or brown in color. But particularly when the frog is at the stage of the reproductive time, then it will turn into the Bekavarna, and in the rainy seasons. And Bekavarna is the Haridra, Haridrata is there. And here you can see, the first one is not the Indian version of the frog, but when it is yellow, it is a poisonous frog. But this is the Indian frog, where you can see that it's the lower part and the abdomen is the Bekavarna, which is the classical in the Kamala. So coming to the Haridra Netra is a very important and the cardinal feature of the Kamala, where we can see that the icterus, the most commonly we will tell that the icterus is the demonstrable change in the color at the sclera when the bilirubin reaches more than 2 mg per dl. Then the person will have in particularly first seen area is the sclera, and that is explained as the Haridra Netra as a first Lakshanas of Kamala. Next is Haridra Twak Naka Anana. See, Twak, you can very easily identify that the whole skin in the abdomen, which we are comparing with the normal skin, it has turned into the Haridra Twak. So Haridra Twak Naka Anana. Okay, so the palmar or the soles, all the skin is turned into the Haridratva. And if you see here also, in a very severe stages, in the progressive stages of the Kamala, there will be the deposition of the Haridratva in the Naka and even the oral cavity, Ananam. So these are the classical symptoms where we see in the Kamala. So coming to the Rakta Pitta Shakrut, so this will become a very important for differential diagnosis between Koshta Shakashita. So even in Koshta Shakashita, the important is the Shakrut and Mutra will be interacting with its color, or it may be turned into the Rakta or the Pita Varnata, not the completely Pita Varnata. It is having the yellowish tinge, or it is the Rakta Pita Varnata can be seen in the Shakrut and in the Mutra at the Koshta Shakashita condition. So after the Koshta Shakashita, so I think Haridra Netva, then Haridra Toknaka Anana, Rakta Pitta Shakrumutra, Bekavarna Hatindriyam. So Hatindriya is also Hatha Indriya means his Indriya function will be lost, and the rest all Dahapa, Kadorbalya or the associated Lakshanas where we can see in the Kama. So coming to the Kumbha Kamala. So Kumbha Kamala, the word meaning of the Kumbha is here, it is denoting the time period. Okay, we have the Kumbha. So Kumbha is here, it is the time period, the long-standing Kamala, okay, or the chronic stages of the Kamala, that is the Kalantarat Karibhuta. So when it is a long-standing, then it will lead for this condition, and it is called as Kumbha Kamala, where the person's Krishna Pita Shakrut Mutram. Then it is still more severe stages of the Kamala will be seen in the Kumbha Kamala. Then coming to the Shakashita Kamala. So Shakashita Kamala, if you see at the end of the Pandu Chikitsa Adhyaya, Shakashita Kamala will start. Then Tilapishtanivum Yastu Varchas Rujti Kamali Sleshmanam Ruddhamargam Tat Pitta Kafa Harijam. So here he is telling that the classical nature of Varchaha. So Varcha will turn into not only the Shweta Varna, it is also Tilapishtanibam. The consistency and the color of the Varcha will be Tilapishtanibam, which is very classically we will see in the obstructive jaundice. And how and why? Because it is obstructed, the Pittaja Marga is obstructed by the Shleshma. Okay, Pittaja Marga is obstructed by the Shleshma. For that only, it's called as Ruddhapata Kamala. Next, if you see that Kafa Sammurchito Vayuhu Sthanascha Pittam Kshipet Balihi Shweta Varchaha. So most of the time the students will be telling that if the Shakashita Kamala is there, Shweta Varcha. It is Tilapishtanibam and the Shweta Varcha is the classical condition seen in Shakashita Kamala. And why? It is a Kapha Sammurchita Vayu. So when the Kapha is obstructing the Pitta and the Vayu is taking the Pitta from its Sthana into the Shaka. Okay, so Pitta is taken out from the Koshta to the Shaka. For that only it is called as Shakashita Kamala. And rest all the Lakshanas like Haridra, Netra, Tok, these all will be same that of Koshta Shakashita Kamala. Only a major difference is the Shwetavarcha and Tilapishtanibam. And the involvement of Kapha obstructing the Pitta in Shakashita Kamala. So coming to, if you want to understand the Shakashita Kamala, so Ranjaka Pitta will be moving from the Ekrut, and it is making the Ranjana of the Rasa, and it is also making the Ranjana Karma of the Mutra and the Purusha. Okay, so it is making the Ranjana of the Mutra and Purusha. For that only, the Purusha will be having some color. So when there is an obstruction by the Kapha, okay, when the Kapha is obstructing, then what will happen? The Pitta is taken out into the Shaka, that is Rasaraktadaya. For that only we'll see the Haridra, Netratok, etc. But when the Pitta is taken out, then there is the absence of the Pitta Ranjana to the Mala. For that only we will see the Shweta Varcha and Tilapishta Nibam. Coming to the Halimaka. So Halimaka is again another stage of the Shakashita Kamala. It is the persons will be having the Harita Varna. Okay, so Hali is the turns into the Haridratva to the Harita Varna. So long standing, when the bilirubin long standing in the extravascular system, then it will oxidize and it will turn into the Harita Varna. That condition is called as the Halimaka, and still there are many Lakshanas are explained for the Halimaka. So this is the major differences between Koshta Shakashita and the Shakashita. So when you are making the understanding of or the treating from the Ayurvedic aspect, we need to examine and we need to take the history of the Koshta Shakashita and the Shakashita Kamala Lakshanas, and in particularly the Varchaha. So Varcha will make the direct differentiation between Koshta Shakashita and Shakashita, and from that our treatment protocol will be continuing. So this is first part of understanding of the Kamala. Okay, Kamala, its Nidana, Sampraptis, Koshta Shakashita and the Shakashita. Next, we will be moving on to the laboratory investigations and interpretation in liver disorders. Okay, so most important is history taking, clinical examination, then the laboratory radiology and the sonological investigations have the role. Most of the time, if you want to diagnose, it is not only on the laboratory. The first thing is we need to take the history, give the importance for the history, then the clinical examination, then the laboratory investigation. So why we will go for this laboratory investigation? The major three things is for the confirmation. So before writing the LFT, we have some probable diagnosis. Then only we should write the LFT, and for that confirmation, we are writing for the LFT and for the diagnosis. Sometimes only from the history and clinical examination is difficult to make the differential diagnosis. For the better diagnosis, we'll go for the laboratory investigations, and lastly, the prognosis. How the LFT will help to make the prognosis of the different jaundice, we'll see in the next slides. And these tests, there are many tests required for hepatobiliary system and for its diagnosis. Some are initial or preliminary screening tests. So whatever we are doing for the LFT, it is a simple preliminary screening test for the hepatobiliary disorder. Still, we have the advanced or the pinpoint, the diagnosis and the prognosis. So before going to actual LFT and its understanding and interpretation, we'll see very briefly about the functions of the liver. See, liver is an biggest gland in the body, and it has a multiple function. It's told that in some books it has 72 functions which will take place every day. Some are like the metabolic function. So it is having the central role in carbohydrate metabolism, lipid metabolism, proteins, vitamins, and minerals. All the metabolism center is the liver. Then it is also having the synthetic function, like it will synthesize the protein, and it will also synthesize the blood coagulation factors. Also, it will synthesize some enzymes. Then another very, very important function is detoxification. So whatever the metabolism is done, at the end, there is an end product, and it is detoxified from the liver, and then it will go into the system. So detoxification, the first and the central area is the liver. The next and the last part is the renal system or the excretory system. Then it will also having the secretory function, like importantly it will secrete the bile. Then it will also having the storage function, like it will storage the glycogens, it will storage the iron, ferritin, and the different vitamins. And it is also having the excretory and the protective functions. Most of the immunoglobulins and the proteins are from the liver. So when this liver is having all the functions like metabolic, synthetic, detoxification, secretory, storage function, when the liver disorder happens, then all the functions, or in some particularly, some functions will be hampering. And for that, we have the different tests. So liver disorder diagnosis is not only on the LFT. So clinical history and the examination, then we have to go for the different investigation. If you are going for the hematological, we may need to see the CBC in the pre-hepatic jaundices, where we need to see the platelets and the RBC counts. In coming to the serum, LFT and the viral markers. In the urine, bile salt, bile pigment is there, and in the covalent. Coming to the liver function test. So liver function test is a group of tests. It's not a single test, and it is a profile. Okay, liver function profile. We call it as liver function profile or liver function test, where there are about 7 to 8 tests are there. So it is a group of tests, and it is a screening tool. It is a screening tool for the hepatobiliary disorders, and our diagnosis or pinpointing the diagnosis is depending on the advanced tests, and the no single test is sufficient to provide a complete information. So why you are doing this about 7 to 8 tests? Because already we know that the liver is having a multiple function, and a single test is not enough to give the complete information of the liver function. Then to make or to diagnose what is the type of disorder and what is the pattern of the disorder. For that, we will go for the liver function test, and what is the extent of the damage and the progression of the liver disorder. So progression, how it is progressing, for that also we'll use the liver function test to assess the different conditions of the liver disorders. So coming to the liver function test, so first is bilirubin. So in the bilirubin, you have the direct and first group of the test. Second is the enzymes, SGOT, SGPT, or AST or ALT. These are enzymes secreted from the liver. This is the another set of in the liver function test. Third one is the alkaline phosphatase, and the last is the total protein. So some people will also add the PT, INR, etc. But this is the classical liver function test: bilirubin, SGOT, SGPT, alkaline phosphatase, and total protein. The rest are or the other tests are the advanced to pinpoint the diagnosis, or sometimes it is used for the prognosis also. So before understanding of the liver function, we will understand very briefly about the bilirubin metabolism. So I think all of you know that the hemoglobin is present in RBCs. When it is got destructed, the heme part and the globin part is separated, and from the heme part there is a production of biliverdin. Okay, so this biliverdin will turn into the bilirubin, and this is called as indirect or unconjugated bilirubin. So the understanding of this bilirubin metabolism is very, very important when we are making the diagnosis of depending on the bilirubin. So biliverdin is turning into the bilirubin, and it is the first, and it is the indirect, it is unconjugated. So next, this will goes to the liver, and in the liver it will get conjugate. So it will get conjugate with the 2-glucuronate, and then we will call it as the direct bilirubin. So why it will become conjugate with the glucuronate? So that it will come or the mixes with the bile, and from the bile it will comes to the intestine. Okay, so this direct bilirubin is coming to the intestine, and in the intestine, due to the bacterial enzymes and due to the different processes, it will turn into the stercobilinogen and the urobilinogen. The stercobilinogen is giving then coloring to the fecal matter, and it will excreted in the feces, and urobilinogen is reabsorbed and it is excreted in the urine. For that only the urine color will be slightly yellow even in the normal patients, in the normal individuals. So from hemoglobin up to the stercobilinogen and urobilinogen, understanding how the bilirubin is direct and indirect, this will help us to better understand the liver disorders. Coming to the jaundice and the LFT. So before going to the LFT, still we need to understand about the jaundice. So jaundice is the yellowish discoloration of the skin and sclera due to the increased level of bilirubin in the serum. So circulating bilirubin is increased, and the person's sclera is the more having the affinity, and there will be the bilirubin deposition, and it is very easily seen in the sclera. then we will call it as then icterus. Then types of jaundice: hemolytic jaundice, or it is also called as prehepatic jaundice; hepatic jaundice, it is also called as hepatocellular jaundice; and the last one is obstructive jaundice, post-hepatic jaundice. So these are the normal ranges of the LFT. So coming to the hemolytic jaundice and the LFT, hemolytic jaundice, it's also called as prehepatic jaundice, where still the liver is not involved. So jaundice is caused by the rapid increase in the breakdown and the destruction of the RBC. As we know that the bilirubin is directly from the RBC. When RBC destruction is increased, then definitely there will be the increase of bilirubin and the person will have the jaundice. And which bilirubin? It is an high unconjugate bilirubin. So high unconjugate bilirubin is a hallmark of the hemolytic or prehepatic jaundice. But when we want to again see or the pinpoint the prehepatic jaundice, we have the intrinsic causes and the extrinsic causes. The intrinsic causes like the G6PD deficiency, thalassemia, sickle cell anemia, etc., where there is an hemolytic jaundice. Then the extrinsic factor. Okay, so most commonly we'll see in the malaria or autoimmune hemolysis or NST or incompatible blood transfusion. What will happen in the malaria? So RBCs are repeatedly destructed. Malarial parasites are there in the RBCs, and it is making the destruction. Then it may lead for prehepatic jaundice. And what will be the picture of the LFT? Total bilirubin is raised, and which bilirubin? It is the indirect rise. Okay, so indirect rise of the bilirubin is a classical or the hallmark of the hemolytic jaundice, and the rest direct will be sometimes direct will be normal, ELP will be normal, SGOT is slightly raised because of the destruction of the RBCs, SGP will be normal, and the proteins will be normal. The next is hepatic or hepatocellular jaundice. Very, very important jaundice and the most common jaundice. Here there is an increased destruction of or the damage to the parenchymal cells of the liver. And the liver is involved, and which is the center of the many functions. Then we'll see the many variations in the LFT. And when you see the hepatic jaundice, we have again the two things. One is infective and the toxic hepatitis, and the defective conjugation. There may be two things may happen. One is there is an inflammation and there is an infection. It is leading for the destruction of the parenchymal cells, even in the toxic. Then it is leading for the hepatitis. And another one is defective conjugation. Whatever the indirect bilirubin is coming to the liver, but it is failed to make the conjugation. So in which are the condition it will occur, and what is the importance of LFT in these conditions we'll see. So infective, all the viral hepatitis, then alcoholic liver disease, and the drug induced. In the drug induced, the most common the hepatotoxic is, we can see that the paracetamol. So overdose of the paracetamol may also lead for the drug induced or the toxic hepatitis, and it is an hepatocellular jaundice. Defective conjugation. So in the defective conjugation, what will happen? There is a reduced number of functioning cells, and the speciality of the liver is, so liver is grade 1 parenchymal cells. It is having some capacity to withhold the most of the damage. Okay, see, for example, our skin is there. If there is a cut of the skin, so skin will go very fast. There is some tissues or some cells which are 0 grade. That means like the neurons. The neurons is once damaged, it is permanent damage. Myocardial or the nephrons, if they are damaged once, they are the permanent damage. But the liver is the one of the tissue which is having some capacity to repair itself, to withhold the damage or the cell injury, but after some limit, then it will turn into the permanent or the irreversible damage. When there is an irreversible damage, like the chronic hepatitis, where we will see the alcoholic liver disease in starting point, hepatitis is there. When it will turning into the cirrhosis, then it is a chronic hepatitis where there is a defective jaundice and the Gilbert syndrome. So in these conditions, we will see the defective conjugation. So conjugation of the bilirubin will not taking place, and there is a variation in LFT. So coming to the LFT in first, that is the infective and the toxic hepatitis. So if you see the bilirubin is raised, and it is the equal rise or the more of the conjugate bilirubin. So direct and indirect equal rise of the bilirubin will be seen. Alkaline phosphatase is normal, and where we have to observe for the hepatic jaundice is the enzymes, that is SGOT and the SGPT. So SGOT and SGPT will be raised drastically up to the 20 times. Then we need to think that it is a most probably it is an hepatic jaundice or the hepatocellular jaundice. Then the protein at this condition, still the protein is normal. Protein function or the synthetic function of the liver is intact. And sometimes we'll go for prothrombin and vitamin K deficiency, etc. So first we need to concentrate on SGOT and SGPT. So when SGOT and SGPT is increased and the bilirubin equal rise is there, then it is most of the time it is the hepatic or the hepatocellular jaundice. Coming to same hepatic or hepatocellular jaundice, but the condition is chronic. Condition is the chronic, where there is no functioning cells for the conjugation. Okay, so conjugation of the bilirubin is not taking place. What will happen? There is a continuous production of unconjugated bilirubin. It is coming to the liver, but it is not turning into the unconjugation. Then there will be the rise in bilirubin, and here it is also unconjugate rise. Okay, unconjugate rise will be seen, and it is the drastically rise of unconjugate rise. Okay. Then we need to very important and very specifically we should see at SGOT and SGPT and the proteins. Most of the time the practitioners will do one mistake. What will happen when the alcoholic liver disease patient comes or any hepatocellular jaundice patient comes? He is having high bilirubin, equal rise, then SGOT and SGPT are high. We will give the treatment, then after some times, okay, bilirubin is also slightly reduced, but SGOT and SGPT is drastically reduced. This is not a good sign. That means there is a functioning cells are losing. And then we should see that what is the total protein. When the functioning cells are reduced, then it will also have the impact on synthetic function, that is protein, albumin and the globulins are reduced. Then we'll think that the synthetic function of the liver is reduced, its functioning cells are reduced, and it is a bad prognosis. We should not assure that, see, the SGOT was very high, now it is reduced. No, it should be, so it will lead for the wrong prognosis. So when the drastical reduce of the SGOT and SGPT, then you should think that it is turning into the chronic hepatitis. Okay, so what we'll see in the most of the time in the cirrhosis of the liver. Okay, before the cirrhosis, the person will be having the high bilirubin and SGOT, SGPT. Then it will turn into the chronic, and we need to concentrate on the protein. And when the protein is reducing, then person will have the swelling and the ascites. So at this condition, the condition of the ascites will start, not in the initial stage or in the acute hepatitis. So in the chronic hepatitis, protein synthesis is reducing, then person will turn into the ascitic presentations. Then coming to the last, that is the post-hepatic or the obstructive jaundice. So what is happening here? The pre-hepatic is also normal. The cells of the hepatic is also normal, but there is an obstruction to the flow of the bile. So obstruction to the flow of bile from the gallstones or the head of the sea of the pancreas and the enlarged lymph nodes, the regional lymph nodes, which are enlarged and making obstruction to the flow of the bile. Then it is an reverse mechanism, and then there will be the obstructive jaundice. And here we need to mainly concentrate on on ALP. So there will be the rise of the bilirubin, and the direct rise will be there. Why the direct rise? Bilirubin is produced unconjugate and it is coming to the liver. Liver is making the normal conjugation, but there is the conjugated bilirubin is not going to the intestine. And here we need to, most of the time, we need to concentrate only on the ALP. So if the ALP is raised drastically more than 6 times, then the person is in the obstructive jaundice. Some of the times the patient is very slight jaundice, and if you send it for the LFT, we'll see that alkaline phosphatase is suddenly rise. Then we'll have the probable diagnosis of gallstones. If the pain is there, then it's okay. Or we have the head of the C of the head of the pancreas, where it is a very silent head of the pancreas is there, and we will have the incidential finding. So we need to concentrate on the LFT and miss this diagnosis, because head of the pancreas CA is there, and if you will intervene in the early stages, then it will have the better prognosis. So ELP will be raised in the obstructive jaundice. So coming to the some very briefly about viral hepatitis and the serum markers. So viral hepatitis is the hepatocellular jaundice, and it is having the different viruses, and in this condition HGOT, SGPT sometimes may be normal. In some stages of viral hepatitis, initial stages or even in a carrier stages, HGOT, SGPT will be normal. And these are needed for making the diagnosis of hepatitis, viral hepatitis. So in viral hepatitis, A, B, C, D, and the E are there. The most important is hepatitis B and the A. Hepatitis B and the A are the most common hepatitis seen and the important hepatitis. Speaking about only the hepatitis B, most of the time we'll go for HBsAg. Then different viral markers, serum markers are there, like the anti-HBsAg, HBeAg, then anti-HBeAg, CAG, and the DNA viral load, HBV DNA viral. Hepatitis B viral load, it's a PCR mechanism where we come to know that what is the stage of the hepatitis. So once hepatitis B is infected, for the long time, for the lifetime, the person will be having HBsAg positive. But what is the state or the condition of the hepatitis B? We can see, or we can make the diagnosis the other serum markers. Why? Because this all, if you see the hepatitis virus, hepatitis B virus, it has the core, it has the envelope, and it has a surface. For all these, we have the core antigen, then surface antigen, and the envelope antigen. Same thing, some are produced at a different levels. For that only, for the exact reason or the exact stage of the hepatitis B, then we'll go for HBV DNA viral load. Then it will tell that what is the exact stage of the hepatitis. So still we have the bile salt, bile pigment. So in some 10 or 20 years back, the bile salt and bile pigment was very important for making the diagnosis of the jaundice. Okay, nowadays we're very rarely we are using bile salt, bile pigment, because most of the information we are getting it from the LFT. So bile salt, bile pigment, it is to differentiate between the another classification, that is a medical jaundice and the surgical jaundice. Then we have the serum, seroplasmin, AMA, ANA, then glutamine transpeptidase, phytoprotein. These all are the advanced test to know the stages or the pinpoint the diagnosis of the hepatic of the liver disorders. So to sum up, so Kamala is one of the Pitta Pradhana and Rakta Dushti Vyadhi. The differentiation between Koshta Shakashita and Shakashita need to be understood with the Nidana and Samapti. So in Shakashita, we have the involvement of the Kapha and there is an Ruddhapatha, obstruction is there, and need to be diagnosed from the history taking and the examination of the stool. And the classical feature of the Shakashita Kamala is Tilapishta Niva and the Shvetavacha. And Koshta Shakashita and Shakashita, in both the condition, we have the Bekavarna, or we have the Haridra Netra Twaknaka Anam. The jaundice will origin from the pre-hepatic, hepatic, and post-hepatic causes, and LFT will become a very main or the screening tool or a major laboratory investigation to differentiate, to make the diagnosis, for the confirmation of the diagnosis, and for the prognosis of the condition. The advanced, like the viral serum markers and the other advanced tests, will help us to make the pinpoint the different stages and to make the diagnosis of the viral hepatitis and the other conditions of the hepatobiliary disorders. With this, I wish to thank DIKSHA E-Academy for giving me an opportunity, and even the Ayurvedic College Coimbatore for giving me such an opportunity to interact with you all. If you have any doubt, you can put it on the chat box.
Thank you very much, sir,
Thank you, ma'am,
for taking your time to prepare for such an extraordinary, enlightening session, which was incredibly informative. We will now go ahead to question answer session. Shall we begin, sir? Delegates, please post your questions in the chat box.
Delegates, please post your questions in the chat box. Sir, we have a question. What is medical jaundice and surgical jaundice?
See, so I told before some years we used to tell that. So surgical jaundice is a condition that is an obstructive jaundice where there is a need of surgical interventions. So obstructive jaundice where there is a need of surgical jaundice is in the surgical jaundice, and the hepatic and pre-hepatic jaundice are the medical jaundice. Most of the time the pre-hepatic is the medical condition, like the malaria. There's involvement of or the need of the medical intervention. Hepatitis, need of the medical interventions. But in gallbladder stones, obstruction by the gallbladder stones, or the stenosis of the duct, then there is a need of the surgical intervention to remove the gallstones, or to excise, or to insert the stent in the duct. So that is between obstruction of the medical and the surgical jaundice.
So we have another question. Please discuss regarding autoimmune hepatitis.
See, in autoimmune hepatitis, okay, so it is also an hepatobiliary. It is an hepatocellular jaundice where there is the antibodies are produced against our own hepatocytes, where the person will show with all the hepatocellular jaundice similarly like that of the viral hepatitis. So sometimes we'll get confused. Is it a viral hepatitis? Or if you take the history, person is don't have the alcoholic or any toxic history, but person is showing the jaundice. Then if you see the LFT, then there is the rise of the SGOT and SGPT and even the equal rise of the bilirubin. Then it is most of the time it is a hepatocellular jaundice. Then we have the different diagnostic criteria, so which are the antibodies are produced against hepatitis, etc. According to that, we will make the diagnosis.
So we have another question. How much significant it is if a person is asymptomatic but the report shows HBsAg positive?
Presently, HBsAg, even though person is having the HBsAg positive, but person may not be having is the person is in the carrier stage or non-carrier stage, and it is depending on the viral load. Okay, if the viral load is high, then the person may transfer to others. Otherwise, even though today HBsAg will get the many conditions which are positive, but it is not going to do anything. And from the Ayurveda, we have a very good treatment and some proved drugs are there which are reducing the viral load. So replication of viral load of the hepatitis. So even the HBsAg is positive, person may live happily and totally healthy. And it is not the genetic. Okay, sometimes it may transfer from the mother to the child, but what will happen when the HBsAg positive woman is there? Then they will see the HBeAg and the viral DNA. If there is high also, no problem. At the time of the labor, immediately after the birth of the baby, they will give the immunoglobulins, and routinely nowadays hepatitis B vaccine is there in the pentavalent. In pentavalent nowadays it is included, so that in the future we may get very less cases of hepatitis B virus.
So the next question is, hepatitis B is for lifelong and is it genetic?
No, it is not genetic, but hepatitis HBsAg may be continuously may be seen, okay, but it is not at all genetic. It may transfer from the mother to the child. And nowadays, as I told, there are many immunoglobulins. Immediately after the birth, they give the immunoglobulins and the vaccine, so that it is nowadays very less transformable.
So the next question. So please tell us about the effective medicine in Ayurveda for jaundice.
Yeah, see, it is a very big topic. Okay, so treatment of the Kamala. Okay, and how to approach for the Kamala. We have and very effective treatments are there. Ekamulika Prayoga is there, and the Shodhana is there. And most of the time, I think all of us know that our Guruji or our Virechana is very, very helpful for the Kamala. So if the person is having the HBsAg, routinely will give the Virechana, and the many hepatoprotective drugs are there. So sometimes even from the modern aspect, when the person is giving, we are giving the anti-tubercular drug. So anti-tubercular drugs are most of the time they are hepatotoxic, and it will induce us the liver disorder or the hepatitis. For that only, I don't know, I should take the name of the brand. So one of the brand, it has given as an adjuvant with the anti-tubercular drugs. So we have very good Ayurvedic drugs which will be having an effective in the many hepatobiliary disorders.
So the next question. Explain the Samprapti of Shakasrishta Kamala.
Shakashrita Kamala. Okay, see, I think we had already discussed it. See, in the Shakashrita Kamala, See, so Shakashita Kamala. So routinely the pitta, so Ranjaka Pitta has to come from the to the Ekruth, and it has to make the Ranjan of the Mala also. So when there is an obstruction due to the Kapha. So when there is an obstruction due to the Kapha, then what will happen? The Pitta will go from the Kosta to the Shaka. So why will take this Pitta from the Kosta to the Shaka? And for that only we can see that the Shweta Varcha. So Ranjana Karma of the Pitta is lost. So Tilapistaniva and the Shweta Varcha we can see in the Shakashtakam.
So the next question. In your experience, whether asymptomatic patient with HbA1c positive report got negative after Ayurvedic medication?
Yeah. So we had seen some of the cases which are turned to be negative after the treatment of the HbA1c of the Ayurveda. But sometimes what will happen, the long-standing HbA1c by itself, it may turn into the negative. Okay. So by itself, it is turned into the negative. For that only still no, we don't have the claim on the hepatitis B treatment. We'll tell that. So it will reduce us the viral load in, etc. But the complete treatment or the cure, we can't still had not claimed. So any pharmacy or anyone is not claimed because it is sometimes it is self-limiting, and after sometimes the HbA1c by itself it may come into the negative. Okay, but at the initial stage, if it is making the jaundice, then definitely we have the very good treatments.
Sir, please share your experience in Kamala and in Ascitus and how to proceed for treatment.
Okay. See, Kamala and the Ascitus. See, most of the time, what will happen? So the person is having the Kamala, but when he has turned into the Ascitus, it is totally the Uddara Samprapti will come, where the person is having the Jalodara, Ekrutodara. So how to connect the Pandu, Kamala and the Udara. So from the Kamala, again, already it is Pittaja and Raktadushti is there, and the important site is the Ekrut. So Ekrut is the center area. So when Ekrut is still more affecting, then it is turned into the Ekrutodara. And from the Ekrutodara, it may turn into the Jalodara. And even from the Ayurvedic aspect, our treatment protocol of the Virechana will not change of the Kamala to the Udara. So both in Kamala and Udara, we may go for the Virechana. In both the condition, the Virechana will help us more. And for the Udara, we need to give the more Tikshna Aushadhi. Okay, so even though it is having the Pittaji involvement is there, but to reach the Udara and to reduce the Udara, then we'll go for the Virechana. And in Udara, another important thing is when the ascites is started, so person will have the loss of proteins. The synthetic function of the liver is lost. For that only, most of the time we will ask the patient to increase the protein intake. Okay, so routinely we will tell that 2 to 3 eggs per day. Okay, when the protein is losing, then we will ask the person to take the protein diet with our routine treatments.
Thank you, sir. Delegates, in case of any doubts, please post your questions in the chat box. Delegates, you can post your questions in the chat box.
So someone is asked about the vaccination is necessary. So nowadays in the universal vaccination, what we are seeing from the national government, so hepatitis B vaccine is already included in pentavalent. Okay, so routinely it is given, and if you want to take the extra vaccine, it is when it is needed when you are living with the hepatitis B virus, hepatitis AG positive patient, then we may go for the vaccination. Otherwise, it is already in the pentavalent.
Delegates, you can post your questions in the chat box. So we have another question. In ascites, the line of treatment, what can be done?
So in ascites, the most of the time we'll go for the Virechana. Okay, so Virechana is the major line of treatment for the Udar.
So we'll wait for a couple of minutes.
Okay.
Delegates, in case of any doubts, please post your questions in the chat box. So we have a question. Classical Virechana.
Yeah. See, in Kamala and in the both ascites, so expected. So we're repeatedly telling the Virechana. So for the Virechana, we will give the Snehapana. And it is told that when the hepatitis is there, its function is reduced, then there is an the metabolism of the lipid is totally derailed. Okay, for that only, so most of the time it is better classically from the Ayurveda, there is no problem, but better to go with the very small doses of the Snehapana, then go for the Tikshna Virechana rather than the classical. So need to modify it according to the condition. And the Snehapana need to be reduced in both Kamala and even in the Udara.
So we have another question. Instead of vaccination, what Ayurvedic medicine you suggest and duration of the medicine?
For vaccination, see, that's totally different. Vaccination is to prevent the hepatitis B virus or the infection. So medicine is when the person is already have the jaundice or the infected with the virus, then we will start the treatment. So vaccination is totally preventive aspect, and the medicine is the treatmental aspect.
Sir, another question. What are the preventive measures we can adopt rather than vaccination?
Okay, see, preventive measures, most of the time it is transferred from the person to person, and the healthcare persons are the most at the risk for the hepatitis B virus. Okay, so need to take care while the needle pricks or the drawing of the blood or any treatment of the person, and it is also can be transferred from sexually. Okay, so in all these conditions, we need to take the precaution so that there is no problem with hepatitis B.
So the next question, oral medicine in ascites. Sir,
Yes, ma'am.
we have a question, oral medicine in ascites.
Okay, see, in ascites or in Kamala, So most of the time, the important is routinely we will advise is the Arogyavardhinivati, which is containing the different things, and the Arogyavardhinivati will act directly on the liver, and it will also reduces the liquid contents or the ascites. So Arogyavardhinivati is the preliminary, and according to the condition, if the person is having the ascites and the person is started with the Pandu Lakshana, then we will go for Punarnava Mandora or the Namaya Sachura. So it is totally depending on the condition and the symptomatic approach. But the Arogyavardhinivati is one of the main prescription for both Kamala and even in the Udara.
Sir, is Ekamolika drug used?
Yeah, in Arogyavardhinivati also we have the Katuki. The Katuki will work very good in both Kamala and the Udara. It is already proved that Katuki is having the hepatoprotective, and it will reduces the bilirubin very drastically. So in both Kamala and Udara, the Katuki as a single Ekamolika Prayoga we can use.
Sir, the next question. The diet in Kamala and Ascitus.
Yeah. See, in diet in the Kamala, the person has to reduce the lipids, and the person already having the loss of appetite. So the duration of the food has to be in, that means the person repeatedly has to take, but in a very little quantity. And the person has to reduce most of the lipids, all the lipids. Then the person has to reduce the non-vegetarian or the which are the food for the heavy for the digestion, and we will ask the person to increase the protein contents, like already told, the eggs. Okay, if the person is having the ascites, definitely we will tell that, so take the 1 to 2 eggs, egg white in the food or in a diet. And all the our Dvidhala Dhanyas is very helpful to increase the protein and reduce the ascites.
Sir, the next question. Is there any prophylaxis medications are there to administer soon after the exposure?
Yeah, see, soon after exposure for the hepatitis, so we'll go for the immunoglobulins. So soon after exposure, we'll give for the immunoglobulin. Before that, we need to think that is the person is really affected with HBsAg or not. Even though he is exposed, it's not mean that the person will definitely get the HBsAg. It's told that HBsAg is most of the time it is more spread, but if the person is viral DNA load is less, then sometimes it may not affect even though if you are exposed. Otherwise, if you are exposed, take the immunoglobulins, and if you are having the direct contact with the person still in the future, then take the vaccinations.
Sir, the next question. Till what range of increased bilirubin level can we treat in Ayurveda?
Sorry.
Sir?
Uh,
Till what range of increased bilirubin level can we treat in Ayurveda?
Okay. There is another condition is called as the kernicterus. Okay, where the persons will have the bilirubin started depositing in the neurons and in the brains. Then it is highly difficult, and the range is depending on the type of the jaundice. See, sometimes the person's bilirubin will be very high. Okay, sometimes 6, 8, etc. So to that we can treat it, but it is the main is the cause and what are the effect of that cause has already taken place on the liver. According to that only we need to decide the condition.
So we have the next question. Please share your experience for treatment of Rutpat Kamala.
See, in Ruddhapatha Kamala, yes, if it is from the gallstones, so when we'll see the Ruddhapatha Kamala, we'll directly go for the USG, and or we'll go directly for the CT abdomen, and we will find out that what is the reason for Rudrakada Kamala or the obstruction. If it is the simple stone is there, not a multiple stone, then we will start giving some same Kamala Hara drugs. Then we will wait to see that is the stones are going out, then it's okay. Otherwise, if it is stenosis is there or the CA head of the pancreas, then it is better to refer. So if the CA head of the pancreas is leading for obstructive jaundice, better it is a surgical intervention rather than the medical interventions.
So the next question, role of sugarcane juice in Kamala and ascites.
Yeah, the most of the people routinely they will use the sugarcane juice. Yes, it is told that sugarcane juice will reduces the bilirubin, and people is taking it as the preventive aspect or before the Kamala also. Then it is of the no use. So when the person is having the sugarcane juice, when the person is having the jaundice, then there will be the more of the virechana and the pitta will be going out. Then it is definitely having some role, and we will also advise.
So we have a last question. How Devadali Nasya works in Kamala reduction?
Yeah, very interesting. So there is the Nasya told for the Kamala. So some observatory studies were done on the Kamala that when the bilirubin is, when we are inserting the Nasya, Tikshna Nasya, so that after the Nasya, it will be draining the mucus. And that mucus is draining the bilirubin. And even we have not only the Nasya, very good question. We have the Nasya and even we have the Anjanas, which are particularly told for the Kamala in the different contexts. But still we need many data to prove that these Anjana and the Nasyas are helpful in the reducing the bilirubin and reducing or the reversing the samprapti of the Kamala. In Nasya, definitely some people uses this Nasya, but we need still more research and the data on these things.
So we have another question. Drugs used as eye drops.
Drugs as in eye drops, no, but in particularly there is an Anjana for the Kamala. Okay, so that Anjana will work for the Kamala, not the eye drops.
So the next question, fluid restrictions in ascites.
Yeah, as the person is already having the ascites, the fluid is accumulating, then we need to reduce the fluid intake and the salt intake and increases the protein intake. Definitely, yes, water intake has to be reduced.
Sir, another question is about Drona Pushpi.
So same, the Drona Pushpi Nasya they might have asked. So the Nasya is definitely working, and even the Drona Pushpi Rasa or the Kasha is also can be administered for the Kamalas. Some traditional practitioners, they use this type of drugs.
Sir, another question, role of Haldi.
Nothing much. Okay, so the turmeric or our direct haldi is better for the increasing of the immunity. Maybe we can take it as the immunity of even the liver, not a direct use of in the Kamala. As a treatmental aspect, will use not much of the haldi or the haridra.
So the next question. After exposure, how many days it takes to show a positive report?
Yeah. See, it is told that the incubation period. So incubation period. Incubation period for hepatitis B is about the 12 weeks. The 12 weeks, then the person will slowly raises the HbS aging. So here you can see that after the contract, so incubation period is the 12 week, then the HbA1c will be increasing. But if really is infected, then the HBV DNA viral load can be seen even in a very initial stage. But minimum 12 weeks we need to wait to see the HbA1c.
Thank you, sir.
Thank you.
So we have another question. I'm sorry, sir. The question seems not clear. Yes, sir, we have the question. How to distinguish the Kamala and yeah. Sorry, sir, the question is not this clear.
Okay.
Delegates, you can post your questions in the chat box. So we have that question. How can we distinguish NAFLD and Kamala?
Non-alcoholic fatty liver disease. Yes. So nowadays we are increasing the cases of this non-alcoholic fatty liver. So when the routinely or when the person is for any other condition, if we go for the scanning or the USG abdomen, there will be the written as the fatty liver, grade 1, grade 2, etc. So our lifestyle is making this non-fatty, non-alcoholic liver disease, in particularly fat deposition, is increasing, and in an initial stage it is totally reversible. Okay, it should not turn into the hepatomegaly and the cirrhosis. So non-alcoholic fatty liver disease is in an initial stage we can diagnose from the USG, and we can very easily treat with the lifestyle modification and some Ayurvedic drugs.
Thank you, sir. Delegates, you can post your questions in the chat box. So I think there are no more questions. Thank you, sir. Thank you for patiently answering all the questions.
Yes, ma'am. Thank you. Thank you giving for an opportunity to interact with you all. Thank you.
Thank you very much, sir. Now, I request Dr. Anu, Associate Professor, Department of Kriya Sharira, Ayurveda College, Coimbatore, to deliver the vote of thanks.
Thank you. Good evening, everyone. On behalf of Ayurveda College, Coimbatore and Team DIKSHA, it is my privilege and a great joy for me to extend a vote of thanks for today's session. First of all, I would like to express my sincere gratitude to Dr. Mahesh Hirulal sir for sharing your valuable knowledge about the topic, Etiopathogenesis of Kamala and interpretation of LFT in hepatobiliary disorders. Thank you, sir. I extend my sincere gratitude to the whole DIKSHA team for providing us with the best virtual platform. Last but not least, let me thank all our delegates who have responded so well to our invitation and made it a grand success. We look forward to welcome you again in our coming sessions. Thank you, one and all.
Thank you, ma'am.
It's the province of knowledge to speak, and it's the privilege of wisdom to listen. Thank you all for your patient listening and the valuable time spent. To know more about our updates, please do stay connected with the social media platforms. That's all for today's most interesting session with lot of information for us to close our eyes with thought-provoking knowledge. Thank you all for joining us. Thank you.